Good morning, everybody.
Hello, John.
Yeah, good morning, Ben. How are you? Can you hear me okay? Can you hear me? Ben, hello? Can anybody hear me?
Yeah. Hello, John.
Oh, okay. I thought you couldn't hear me. Yeah, did Juha have surgery or something, or what?
Hello, John.
Yeah, can you hear me?
Can you hear me?
Yes, I can hear you. Can you hear me? Can anybody hear me?
Yeah. Now it's okay.
Okay. Yeah, what happened to Juha? Can anybody hear me?
Hi, John.
Yeah, I think
The
is
voice
your
is
audio,
not very good.
you can't hear me very good. How about anybody else? Can anybody else in the audience help me? Can anybody hear me? Hello, School Brain Project. Can you hear me?
Good morning, Mr. John. Yes, I can.
Oh.
If possible, hear to you.
Okay, thank
Okay.
you. Thank you.
Thank you.
Yeah.
Okay, good. It may be, what happened to Juha, Ben? I think. So my hearing is, my sound is okay, right?
Hi, John.
Yes, can you hear me now? Yeah, I think your audio, Ben, is something's going on with it. Hello, because it seems to be working on my end, okay. But your audio doesn't seem to be consistent. Once again, can anybody hear me? Can anybody hear me?
Yes, I can hear you, John.
Okay, good. Thank you. Thank you. You're muted there, Ben.
Hello, John.
Yes, I can hear you now. Can you hear me?
Okay. Now it's okay.
Okay.
So
how you been?
can you see my
Yes, I can see it.
screen? Yeah.
Yeah. Do you have videos?
Yes.
You'll want to go over the video?
Yeah. Can you see the video?
Yes, I can see it.
Okay.
It looks fine.
Okay. Now I have to. I couldn't use a high resolution one.
Right,
Because it-
right.
Yeah. The file is moving.
That caused the
Yeah.
problem before, right?
Yeah. Yes. Okay, I stopped it.
Okay.
Okay.
Did you have surgery?
Yeah, maybe. I'm not sure. He just told me that tonight
Yeah.
he could.
Yeah, I didn't get an
Yeah.
explanation. Just I
Mhm.
can't do it. I wasn't sure.
Mhm.
But that's okay. That happens.
Okay.
Everyone expects it.
Yeah.
It's no big news.
Mhm.
Are you going to Spain this year if it's open in January with Lewis?
Yes.
You're gonna go?
Yes.
Oh, good.
Yeah. This year I also go to Madrid.
Well, Lewis takes you on a tour of Madrid.
Yeah.
Oh, it's great.
Yeah,
He takes you
yeah,
to the
yeah.
Prado and takes you to
Yeah.
dinner, and it's very nice.
Yeah.
I really enjoyed it. The year that you couldn't come, was it last year you couldn't come? Oh, you had problems, but we televised you anyways. Here he is now. Hey, Lewis.
Hi, I
How
am
you
here.
doing?
Hi, Luis.
How are you?
We're just talking about Spain.
Yes,
How we want to see you in January.
yes, of course. With the team of Shanghai team.
Yeah.
Juha don't speak today.
No, he's not.
Yeah.
No, he's not coming.
Okay. If you want, you are more time, Professor Bean.
Hi.
If you want to start, you need more time with your conference. Perfect. Don't worry. I only speak
Okay.
10 or 15 minutes. My presentation.
Okay.
But
So
listen you.
So you go first on me.
What do you want? Do you prefer to start, or what do you want?
Okay. So
Yeah, once you start, Ben.
Okay.
Okay. In 1 minute we start.
In 1 minute. Just start, then. Just start.
Yeah. Is your friend Victor?
Hello, John. How are you?
Hi.
That's
Hi,
Victor.
How
Hi,
are
Victor.
you? How are you
Fine.
doing?
Nice to see you again.
Yeah, it's a pleasure. It's a pleasure to meet you in this webinar.
Thank you.
I am really amazed seeing your microanastomosis. When I was with Dr. Juha in Guangzhou, it's really impressive technique. I think very few brain surgeons around the world make that kind of surgery than you.
Thank you.
Dear friend, may I have your telephone number to be in contact with you?
Yeah, no problem. I can send you the email.
Yes, thank you so much.
Yeah.
I can give it to Victor. Are you ready to start, Ben?
Okay.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It's Dr. John Bennett of Neurosurgical TV. We have the pleasure of having Juha's neurosurgery grand rounds. Unfortunately, Juha cannot make it today. We have Ben Zhu, he's going to talk about endovascular bypasses, and followed by Luis Lopez Ibor from Spain. So welcome, Ben, it's all yours.
Okay, thank you. So today my topic is about the bypass for giant ICA aneurysms. So I come from Huashan neurological department. We are a huge department. We have 4 campuses. Totally, we have 800 beds. And we are the WFNS and the ACNS training center. And 2 weeks ago, our chief, Professor Mao Ying, he just becomes the head of the Juha hospital. So this is my personal experience in bypass. Now I have more than 7,000 bypass, including 311 bypass for aneurysms. For the intracranial giant and the complicated aneurysms, now we have more and more interventional treatments like fluid diverters, but the fluid diverters still have some problem. It have a quite high recurrence rate or delayed occlusion of parent artery or the important perforators. So sometimes the direct clipping is not, couldn't achieve because some of the aneurysm dome was too large. And sometimes the aneurysm wall have some calcification, so it's quite hard to clip. And sometimes it's very hard to protect the perforators. Now we have different fluid diverters, including pipeline, silk fluid diverter, or thread, surpass, and in China we have a tube bridge. It's manufactured by Macroport company. So like this case, this is a very giant aneurysm at the cavernous segment of ICA. After the fluid diverter, you can see the vessel cavity was totally reconstructed and the aneurysm was cured. So bypass for giant aneurysm still need in some cases. We should make the plan for blood flow replacement. Normally it's ECIC bypass. Now around 80% of this giant aneurysms of ICA was treated by fluid diverters. Or sometimes if the aneurysm located at the cavernous sinus, we also can use covered stent. So less and less cases need bypass. Now it's in our hospital, my personal cases is less than 20 cases per year for the giant ICA aneurysms. So the bypass is a hemodynamic treatment of the aneurysm. Normally, it's combined with trapping of ICA of the ICA. Sometimes it's a proximal direct occlusion of ICA. Sometimes we use a progressive proximal occlusion of ICA. This is a quite useful strategy. So the purpose is to decrease the pressure of the aneurysm or keep the blood flow in perforators and keep the blood flow of distal parent artery. So this is our tailored bypass for ICA aneurysm. Before the surgery, we should estimate the natural collateral blood flow make sure to get have enough blood flow replacement. Before the treatment, we always do the balloon occlusion test. Normally, it's 30 minutes balloon occlusion. If it's negative, which means neurological deficit was just negative, we will treat with enhanced BOT, which we will decrease the blood pressure around 30%. If it's still negative, so this kind of ICA can occlude it directly. But if the patient couldn't tolerate the enhanced BOT, so this kind of patient still need the STA-MCA bypass combined with the ICA occlusion. So if the patient couldn't tolerate the routine 30 minutes balloon occlusion test, we should make the plan of blood flow replacement. If the ICA only feeded the unilateral MCA territory, if the patient is a male, the STA diameter is larger than 1.2 millimeter, we could use the STA to MCA double bypass. Normally, it's enough to replace the whole MCA territory. If the patient is a female, the STA double bypass was not enough. We still need the radial artery transplantation. So it's a combined bypass. If the ICA feeded not only the MCA territory, but also the same side ACA territory, this kind of patient need a radial artery transplantation. If it's not only feeded the same side of the MCA, but also the bilateral ACA territory, so this kind of patient need more blood flow. So this we will use radial artery to MCA, combine the STA to MCA double bypass, or sometimes we also use the saphenous vein to MCA bypass. So this is our strategy from no bypass to saphenous vein. So this is a type 1 ICA proximal giant aneurysm. This is a male patient, 46 years old, and he suffered a sudden right hemiplegia for 3 months. We can see the infarction at the left basal ganglion. So this is an aneurysm. It's extracranial aneurysm. It's a very giant one. In the radiologist tried to put the pipeline in the aneurysm, but it's failed. So they referred the patient to me. So this is a preoperative DSA. We can see the very little collateral blood flow from ACAAN and the PEDIATRIC. So I still use this, the simplest technique in anastomosing, which means very fast technique. Only the mean temporal occlusion time only take around 13.5 minutes. So this is a loop technique, can save the movements even less. Yeah, sometimes it's even faster. So this is painted by Dr. Cai Li. So it's still interrupted suturing. So normally it's 12 stitches. So I'm sorry, I have to sacrifice some resolution because the high resolution video was too large. So it's quite simple. Today I have 9 bypass for Moya Moya, just today. So this is after the double bypass of STA to MCA, one in superior trunk and one in inferior trunk. We can see the ICG. The double bypass was all very patent. And after the double bypass, we get the proximal occlusion, partial occlusion of the ICA, just at the distal part of the bifurcation. So this progressive clip was designed by me. So this is after the surgery. In 7 days, we were totally occluded the ICA. So this is after 1 week, we totally occluded the ICA. Then we check the double bypass was all patent. We can see almost all the MCA territory was replaced by the double bypass. So after 7 days, ACAAN and PCAAN also getting larger, and we can see the some collateral from the contralateral ICA and the basilar artery. So this is a type 2 ICA aneurysm. Also a very giant cavernous sinus aneurysm. We can see this is larger than 20 millimeter. So this is a balloon occlusion test. We can see there's no collateral from contralateral ACAAN, and the PCAAN is also very small. So this kind of patient, the blood flow replacement should cover the MCA and the ACA territory. So the whole hemisphere should be replaced. So this one, I use saphenospan, ECA saphenospan to MCA bypass because blood flow was good enough, and we can see the angiogram shows the bypass already replaced the same side, ACAAN and MCA and ACA territory. So this patient, we get the direct ICA ligation immediately. So this is a type 3. It's also ICA aneurysm. We can see the poor collateral A1 and the PCAAN. The A1 is small, but there's still some blood flow come from A1. The PCAAN is very small. So the blood flow, but it's better than the last one. So the blood flow replacement should cover the left MCA territory. Because this is a female patient, I already mentioned that this female patient, the STA was quite small. It's around 1 millimeter. So we still need the radial artery transplantation. So this is a ECA, radial artery to MCA bypass. Then after the surgery, we did the angiogram immediately. and we can see the bypass already covers the whole MCA territory, and even the blood flow even reflux to the ICA distal part. So then we occlude the ICA directly. So this is another case. We can see it's also a similar case. We can see after the ECA radial artery to MCA bypass, we can see the ICG angiogram shows that blood flow was very good, and the MEP, SCP was all good. So then we occluded the ICA directly. So this is the ECA to radial artery bypass. This is a ECA stoma. After almost finished the stoma, we regated it with this heparin saline, then closed the stoma. So this is a type 4, even more distal ICA aneurysm. We can see it's a good ACAAN, and we can see the A1 was quite large, but it's delayed. The balloon occlusion test, 20 minutes is negative, but 30 minutes is positive. So the blood flow replacement should cover partial MCA territory. This is a young man. His STA was quite large. So I use double STA to MCA double bypass. That's enough. So I also combined with progressive occlusion of ICA. We can see after 1 week, the double bypass was all patent, and this is the traditional progressive clips. At the first day, we narrowing around 70%. Then at the after 1 week, we totally occlude the ICA. So this is after the surgery, we can see the double bypass was all patent, and still get some ACAAN and the PCAAN collateral. This is a type 5 ICA aneurysm with the cavernous sinus syndrome. The balloon occlusion test was negative. We can see the balloon occlusion test. The ACAAN was quite good, and the A1 was also quite large. The CT perfusion, when we occluded the ICA, was still good, but the enhanced balloon occlusion test was positive, which means the blood pressure decreased to 30%. The patient couldn't tolerate. She got some ischemic condition. So this kind of patient, we still need the bypass. But for this kind of patient, only replace a partial MCA. So the left STA to MCA bypass combined ICA coiling. So we can see after the double bypass of STA, the bypass was all patent, and then we use the coils to sacrifice the ICA directly. So this is a take-home message. For tailored bypass for ICA, the balloon occlusion test is very important. And for the negative one, we use the enhanced balloon occlusion test, which means blood pressure decreased 30%. So only this kind of patient, it's still negative, we can sacrifice ICA. So otherwise, all the patients need the bypass. Thank you.
Very good, Ben. Thank you very much. And okay, we're open for discussion now. Louis, you had a question?
Yes, yes. Thank you very much, Professor Bing. I like fantastic your technique. Eh?
Thank you.
Really, you are a very good technique. One question. Where is your? You explain a little bit more. Where is your method to occlusion test? What with balloon, with why?
Yes, with the balloon.
Yes, and the patient, you decrease the pressure, blood pressure.
Yes, this is we call it enhanced balloon occlusion test.
And the second comment is or question is when the balloon when you place the balloon proximal to neck, only in the bifurcation.
Yeah, distal to the bifurcation.
Okay.
Distal to bifurcation.
I have one case, a rupture of the vessel in the balloon test, just because I put the balloon very proximal to the neck of aneurysm. I think it's more preventive to use the balloon about 1 centimeter before, because the wall of the vessel is not it don't have quality proximal. Yes. And you're testing how long you're occluded. How long? 10 minutes?
Normally we use 20 minutes. If it's still negative, we may prolong to 30 minutes. If still negative, we will use the decreased blood pressure. If the patient is all good, then we can sacrifice this ICA directly. So only this kind of patient we directly sacrifice ICA. Otherwise, if the patient got some ischemic symptoms or some headache, we still need some bypass.
Very interesting. And what is your strategy when you are a bigger aneurysm, a large giant aneurysm, and you think you need to close the vessel before you attempt one bypass? At the same time, you close the vessel, or you wait 1 week or some days?
Yes, actually, may I share my screen? Yeah.
Yes.
So this is our strategy for the tailored bypass. So only the first kind of patient can tolerate the enhanced balloon occlusion test. This kind of patient, we can sacrifice ICA directly. Otherwise, we will still use the STA to MCA double bypass, or sometimes if the patient need more blood flow, we will use radial artery. Sometimes radial artery combined STA, and if the patient, the parent artery of the aneurysm feeded both sides of ACA territory and the MCA territory. For this kind of patient, we use saphenous-span.
Thank you. Okay.
Okay, very good. Victor, do you have any comments or questions for Ben? Are you there, Victor?
Yes, yes.
Okay.
Just a comment is really impressive to see the technique of this microanastomosis. I have been several times in Henshu with Dr. Juha and also with Binshu, and it's impressive technique to make this kind of microanastomosis. It's not easy to make 200 or 300 microanastomosis in our countries. But in China, I understand that you have too many patients with moya disease and another kind of vascular lesions. But although this is the numerous kind of surgeries, it's impressive to operate more than 7,000. Congrats, dear friend Binshu. Yeah, that's it.
Okay, more comments or questions for Ben? Okay. Okay, very good, Ben. Thank you very much for another great presentation. And I guess if there's no more comments or questions, we'll move on to the presentation of Lopez Ibor, aneurysm embolization and pediatrics.
Okay.
Okay, Luis.
Yes. ¿Cómo hago otra vez? ¿Tengo que abrir?
Luis, English.
Yes. Well, I like to.
Are you going to open?
I need to open before, no?
Okay.
Open before, yes.
Yeah, it's better that way.
Just a minute.
You've done it before. It'll come back.
Yes. Yes. And now compartir. Just a minute.
Yep. It'll come back.
Yeah. Perfect.
There you go. There you go. Make it bigger. There you go.
Okay. Okay. I thank you, John, and good afternoon and good morning, every seminar. And I present only few case, a special case of pediatric aneurysm embolization. Is 10 patients have 12 aneurysms. This is the localization and age. Male of 50 months, callioso marginal, ICA, MCA, gyrus marginali, petrocavernous vertebral, left pica, basilar tip, and bifurcation. This is a blister aneurysm. Okay, the first case is a boy, 8 months, have a frontal and subdural hematoma, and the neurosurgeon removed the hematoma and partial lobectomy. And in the first angio in emergency, the angio is negative. But 3 months later, I have a control angio, and in AP view, you are lobectomy, hypovascularization of this part, anastomosis, leptomeningeal anastomosis, and 2 dissecting aneurysms around the forks. This is a pericallosal artery, and this is the forks. Probably it's post-traumatic. This is in lateral view. And the problem to treat this is if you navigate here, the A2 in the left side, anterior segment A2, is too small because I have a lobectomy. This is the right pericallosal, but this is the left hypoplastic, and this. To treat this, I decide to navigate with the small microcatheter magic to this point, and then glue it. And the diluted fluid is totally occluded the aneurysm. This patient was treated about 2022, 21, 2001 or 2002. Sorry, I used the onyx, not the glue, onyx. Finally, the patient don't have deficit, major deficit, and total cure both aneurysms. This is post-embolization. You are here, the left anterior carotid, anterior segment, E2. You are collateral circulation of leptomeningeal, a posterior pericallosal anastomosis. Here is the onyx. And this is the control in the carotid artery. Second case is 7-year-old neurofibromatosis and seizure. I have a bilateral giant aneurysm, dysplastic in the right, in the left. This patient is treated also in 2000, 2001. And also have dysplastic aneurysm in posterior communicant artery. I decided to put some coil to prevent this part of aneurysm and don't touch this part. In this period, I don't have the flow diverter devices. Another patient, 12-year-old, hematoma and seizure, aneurysm in the left hemisphere, gyrus marginalis, selective. I'm coiling. This patient is about in 1984, 1985. After coiling, but I decide to surgery 3 months later because growth the aneurysm is the first or the initial case of GDC coils in my experience, in 92, 93. Other complex case, treated in acute phase, 2-year-old boy with intraventricular hemorrhagic, ventricular drainage, grade 4, in arrival to hospital, and 2 weeks later, after bleeding, going with my center. And this patient have a pericallosal aneurysm. This is oblique projection. This is A1, A2, and this is a fusiform aneurysm, AP view. And I decide to put coils and test occlusion with coiling. In this moment, I see the contrast, stagnation, the contrast inside the aneurysm. And in the late phase, I have a good collateral leptomeningeal anastomosis. It's general anesthesia, it's impossible to test the child, is 2-year-old. I decide to liberate the coil because I have a good collateral anastomosis. This is before, this is after. And late phase, you are the collateral anastomosis. This is few months later, you have the total collateral anastomosis and reconstruction of the vessel, a total occluded without symptom. This is 3 months later, angio stabilization. The patient at the moment is very fantastic. It's not down deficit, very good, very good. Other more complex case is a female, 40 years old, fusiform giant petrous and internal carotid right aneurysm. Left. AP view, lateral view. But this patient have occluded, spontaneous occlusion of the siphon in the right side. Only the right carotid down the ophthalmic artery. The neurosurgeon performed 2 bypass, one in the right, another in the left. And then still the patient, because the surgeon talked with me, neurosurgeon, Luis, it's possible you put a balloon distal part, and you put the balloon and the patient is well, I don't operate the aneurysm, okay. I navigate, it's very odd case also. I put the balloon. Look this, before treatment, the anterior communicant artery is still open, and you have the middle cerebral artery in the right side. This is the right carotid, the internal carotid artery, only ophthalmic, and collateral anastomosis with inferolateral trunk and some branch of the middle, but very poor anastomosis. Test balloon occluded. The patient are well, but 24 hours develop hemiparesis and aphasia. This is the balloon. This is an MR 1 week later. Total occluded the balloon, the aneurysm. The patient recovery slowly recovery to this hemiparesia. And the evolution is well, but 5 years later, I have a control. You are the collateral anastomosis with posterior communicant artery still open and now open. And this is the evolution. This patient have one dysplasia, vascular dysplasia, elastorhexis. I think it's LM Darlons. And 20 years later, after this control, the patient going with my consultation and bleeding and death. Another case, the male 30-year-old, also neurofibromatosis, middle cerebral fusiform aneurysm, is treated in 91. Before a period of coiling, I only treated the patient with a balloon. This is a MR. You have edema or gliosis around. I treated with a balloon. You have stagnation, the contrast. The patient that has an external anastomosis, still well, and the balloon only placed in this part, and this is the control. A partial thrombosis of aneurysm, but still the patient well. Other patient, 3 months, mild pseudoaneurysm of the vertebral, right vertebral. This is MR, axial view. Probably is secondary, this is dissecting aneurysm by punction. I treated in this period with a balloon, put the balloon here, detachable balloon. You see the balloon before, after, and thrombus in the aneurysm, totally occluded. Other complex case, Glasgow 5, subarachnoid hemorrhagic, in emergency treated with coiling, and 2 weeks later, I treated with a stent. This is coiling, and this is a balloon expandable stent in this period, cardiac stent. The stent is here, and the stent is here. You have the cell, the stent, the coil, and packing a totally occluded aneurysm. Other complex, 3 months, year male, 3 months, come with a Hampton-Hughes 5 hemiplegia, and only with my microcatheter spasm, I put coiling in the aneurysm and coiling in the neck, totally occluded in emergency. This is the last case. It's a difficult case. It's a blister aneurysm treated in 2005. This is the blister aneurysm, large neck, and a small fundus. Oblique projection, catheterization, and coiling, and protect the aneurysm of the patient well. This is the result of this series of 10 cases of neurofibromatosis, partial occlusion, both occluded aneurysm with different techniques, coil, balloon, coil stent, onyx. Complication. In the petrocavernous, 1 year hemiparesias, but 1 year later improved, but 20 years later, the patient rebleeding and dead. And the MCA aneurysm of Recklinghausen have a and my patient been finally recovered. Okay, thank you for your attention.
Okay, Louis, thank you very much. Ike, are you here?
Yeah, I'm around, John. I'm around, but maybe Subin can moderate. And is Juha not here?
No, Juha's not here. No, he's not here today.
Yeah, my regards to Luis and Subin, and maybe Subin can moderate.
Okay, Subin, go ahead, Subin. Are you there, Subin? First of all. Oh, no, he's busy. He's busy with technical things. We'll just open it up here to the panel if any questions or comments for Louis. Here, Louis, I'm going to bump you off the screen there.
Hello, Luis Lopez.
Yes.
Hey, Victor.
How are
Good to see you, Victor.
Hello, Ike. Nice to see you here. I have a question, Luis Lopez. Your patients were treated in which period of time? I mean, when was the first child with this kind of aneurysm, and the period of time to treating them? So how many aneurysms in child have you seen and have you treated in your experience?
Yes. In this revision,
和我这里的所看到的屏幕完全对不上。
In this example, I treated in acute phase every case of the bleeding aneurysm and small, not the giant aneurysm. And I have more than 30 patients of child aneurysm. No more. It's not common. It's very rare pathology. But when you are the patient with the complex aneurysm in the child, is difficult to choose the method or the device. Now it's most easy because you are fully diverter or you are more material to coils, different coils and balloon remodeling. In this period, I don't have this material.
And how many of them with genetic disease? You told us that one of them had Ehlers-Danlos disease and other two more neurofibromatosis.
Yes. Yes.
Only three?
Yeah, I remember only three. Yes.
Okay.
Also have aneurysm, but mycotic aneurysm is with this is most common.
Okay. Thank you, Luis. Congrats.
Thank you. Thank you.
You are mute, John Bennett. You are mute.
I'm sorry. Yeah, thank you very much, Louis. If there are any more closing comments or questions from anybody in the panel? I know Ben probably had some, but he's too busy. He's that way. He's working hard.
Yeah, actually, I'm translating, but you know, today the screen is delayed a lot in my side, so I couldn't see the cases very clearly. Only I could only see Louis' presentation. Maybe presented 4 slides. So I don't know why. Yeah.
Well, that's the Chinese website that's having issues. It happens all over the world.
Yeah.
Okay, great. Okay, thank you, everybody. We're going to close this next week. I think Juha will be back, hopefully. And thank
Okay.
you very much, Ben, for all your work and for translating and doing promotion. Thank you very much. And thank you, Louis, Victor, Ipe, and everyone else for coming. And we'll see you guys next week.
See you.
Thank you.
See you
Okay,
next
see
week.
you. See you
Thank
next
you
week.
so much. Bye bye.
Thank you. Bye-bye.
Okay, we're off the air there.